Greeting, everybody. We're going to start in just a minute or so, just giving everybody an opportunity. If you can shoot your name in the chat and your license number as usual, so we can make sure you get recorded there. And we'll do some introductions here in just a moment and get everybody underway. All right. I would like to welcome everybody to our webinar today of building a defensible patient-centered authorization process for EMS agencies. Today, we're joined by Donald Sheets from the Maine Community College System. Don is a lifelong learner and has spent a significant amount of his time in leadership at the community college system. He's also served as a department chair, a clinical coordinator for EMS programs. He was also at one point the education coordinator for the state of Maine with Maine EMS. He is actually a third-year law student at Vermont Law and Graduate School. So he will have some insight from there. We do want to say clearly that he is not currently an attorney. So he cannot give you legal advice, and none of this stands as legal advice. So today he's going to talk to us about how to do a credentialing process for your agency. Don, are you all set?
I'm good to go.
All right. The floor is yours, sir.
Thank you, and welcome everybody. I appreciate you joining today. So a couple things that I want to point out are this is the second in a series of instructor programs that Maine Medical Center EMS has put together. There will be one coming up in September with Aidan Koplowski, the program director from Eastern Maine Community College. He'll be looking at competency-based training, which we tried to actually build this so that his discussion will actually build a little bit on what I'm talking about today and dive in a little bit deeper on some of the topics. And then Leah Mitchell will be doing providing feedback in October. So if you've not already heard about those, we'd love to see more people involved at those. And then disclosure and conflict of interest, as Eric said, I'm going to make very clear, I'm not an attorney. This is really based upon observations I've made throughout my career and best practices that I've been working to research, and I have no other conflicts of interest. So thinking about credentialing. So this could be viewed as a challenge or an opportunity coming to leadership and department culture in a department near you. I think this is, interestingly, we started talking about putting this together prior to some of the recent events around PPA EMA, and I think this is really timely that as we're looking at agencies needing to register and potentially adopt some new policies and procedures, I think this will actually tie in nicely to some of those conversations and actually can be a genesis for why you might want to really start looking at this. So for those of you who are educators in the room, which I know many of you are, I'm watching names fly by in the meeting chat right now. This should look really familiar. It's out of the EMS scope of practice document. And what I always like to point out here is we talk a lot about the education component of this. And this is really looking at what is actually a provider scope of practice is the center of the Venn diagram. And it's where education, certification, licensure, and credentialing all overlap. Obviously, education is happening with initial education, whether that's through the community college system or an external training center. Certification is really looking at the National Registry of EMTs and the exams that students have to pass there. Obviously, licensure is the state of Maine and the standards that they hold, but we don't talk a lot about the credentialing component of this. And that's what we really want to focus on today is what is that credentialing? Something else that I didn't mention, I really honestly don't enjoy this style of format of presenting information to people because it feels very one-sided. So if you have questions, please put them either in the Q&A, the chat. I believe we also may have the opportunity if you raise your hand to unmute you. But I'd love questions as people are listening. If they come up, throw them somewhere and I'll try to answer them as we're going. That feels much more natural to me. So what is credentialing? That's the big question that we're gonna tackle today. So credentialing is truly the formal verification and authorization that allows an EMS provider to practice within an agency under a medical director. This often is confused with the fact that someone is licensed. Licensure is simply that, it's licensing, but in other areas of healthcare, the providers actually have to go through a credentialing and privileging process. So what I want to make sure we're clear on is that this is not a point in time. This is an ongoing process. We think about quality assurance, quality improvement. That is a process. It's not a point in time. So really, this is something that should start from the application period. There's a verification component. There's a competency testing. There's medical director approval. There's an active status. And then there's an annual review that goes into this as well. So this is similar to renewing your certification, renewing your license. This is an internal component within the agency of ongoing learning and evaluation. And I want to make really clear that as we're talking about this, this is not intended to be an I got you moment. This is an opportunity to continuously evaluate providers and process and ensure that we are providing good care to our patients. So why do we care about the credentialing component? This is really about patient safety. That is first and foremost why we want to credential providers is we want to ensure that quality patient care is happening and that patients are safe with the care that they're receiving. But in addition to that, there's two other benefits to this. This is an opportunity to actually provide some protection for employees, for the providers, and for the municipality or the department agency as well. So one of the things that we're going to do is we're going to talk about this kind of in a case-based. I'm going to bring up a case that we're going to discuss, and it's going to help shape some of this conversation. So as most of you are probably familiar, in 2019, Elijah McClain died while in police custody in the care of EMS. I'm going to introduce this. I'm going to just provide some background information, and then we're going to touch back on this after we talk about some other components. And I really want to stay focused on the patient care component of this, not any of the political things that happened around it. But Aurora PD approached McClain on the side of the street. He ended up in custody. They called in paramedics. They reported that he was incredibly combative, that he was basically raging, and he was administered 500 milligrams of ketamine. The correct weight-based dose was closer to 325 milligrams. And ultimately, he went into respiratory arrest and died while being transported to the hospital. So we're going to start there, and I want people thinking about this in the background while we're talking about some of these other things, and then we're going to come back to it in a little bit. So if folks could, I want you to think about what is your current onboarding process for a new employee, and what are the components, what are the things that you do, and if you're willing to do so, throw some of those things in the chat so we can kind of share what people are doing right now. And this is where I'm going to sit and stare at all of you until somebody starts doing it. All right, so I see license verification. There's one. Writing is a third. Keep throwing those in there if you've got other things. Vaccination status, that's another one. So if you think back to great extensive orientation with the above, also probationary period under guidance of another paramedic, background check. Now the answers are coming in. Great. From background checks. Great. So these are all good components. Social media check. That's a good one. exclusion list. Fantastic. All right, so there's some good components here. And if you think back to the slide earlier that I had around what the various different components are, we had the application, then we had the verification. So in this verification step, and some people are putting in some of these things here already, which is great, doing primary source verification. So do you just accept a provider handing you a paper copy of the license, or do you go actually check their status? Do you check their status with the National Registry? Are you setting up licensing alerts for providers, screening the background, checking driving records? These are all things that we want to be doing throughout verification. When I started working for the community college system, one of the requirements was that I have a degree. They would not allow me to give them a copy of my diploma. I actually had to have official transcripts sent from the school because they wanted that primary source verification. It's no different when you're thinking about bringing a new provider on. You want to make sure that you're doing that primary source verification to ensure that they have the credentials that they're telling you they have. So then we start thinking about the next step, and we're looking at that initial competency evaluation. And there's four major components that we think about with credentialing, and this is one way to go about this. So do they know their protocols? How are you going to evaluate that? You're really thinking about a written exam, skills testing and skills competency, clinical decision making, which we can do through scenario-based evaluation, and FTO clearance. And what's great is some folks already put some of these things in here, and it means that it's already being done, which is really helpful. So that's the initial competency evaluation that we're really thinking about with our providers and ensuring that this is getting done. How you do this, we're going to get into in a little bit more. And then some of the, like I said, Aiden will be talking about some of this ongoing competency stuff in much more depth in a later portion of this series. But then there's the medical director authorization. This is actually a formal sign off by the medical director. And this can include specific skill privileging, which is not something that EMS locally has been doing a lot of. So when a doc or an APP goes to work for a hospital, there are specific things that they are allowed to do within that facility that they may not be able to do elsewhere. And vice versa, they might be able to perform certain skill sets while working at one location and not another. And that privileging that we don't do a lot of in EMS. So that's the initial part. And then we have the annual evaluation. How do we then repeat these things? So going back through, have there been protocol updates? Have we evaluated whether our providers are familiar with those protocol updates again? Are we checking on skills? Are we checking on decision making? All of those components have to come back in an ongoing fashion to ensure that there's this ongoing competency. And again, this isn't intended to be an I got you moment. This is intended to be if we find a gap, now we're going to work with that provider to fill it. And this goes back to like anything else with QA, QI. We want to ensure that if we identify a problem, then we want to evaluate, is this an individual provider problem, or do we actually have a systematic problem that we need to address on a larger scale? And that's another component that's beneficial of doing credentialing, is it can help you identify these larger issues within an agency that you might otherwise not discover simply because it's not an area that you're investigating. So let's get back to our case here for a moment. Paramedic gets 5 years in prison for the death of Elijah McClain. So there are actually two paramedics that were charged in this case. Both had convictions. And there were several law enforcement officers who were charged who also received convictions. Now, full disclosure, some of these convictions actually have been overturned. In fact, the two paramedics had convictions overturned on Friday. What I want to make clear about this is the reason their convictions were overturned was because the jury received inappropriate instructions about the standard for conviction under negligent homicide. They were told to use the plain meaning of the words. The actual standard in Colorado where this occurred was the reasonable standard of somebody in the same profession, and the decisions around that. Why I'm making that distinction is there is, I think, a likelihood that the Attorney General will choose to retry these cases, or they may appeal it to a higher court to see if they'll actually overturn it. What is important is actually the assault convictions were actually upheld in this case. So the one paramedic who was guilty of assault actually still has they still had the requirement for prison time, which did get altered to probation based upon the longevity of their work and other things. But I bring this case forward and have this conversation because there were a lot of missed opportunities at the agency and provider level to prevent this from ever happening. And this is where I think credentialing can really come in and can initiate a lot of conversations to protect. In this case, I think providers were put in a challenging situation. And there were some poor decisions made. Ultimately, they relied upon the report from the police department to make their treatment decision for this patient. There was really no assessment that was ever done, and the communication was really minimal with the patient. So as part of this, this is a good piece of having ongoing conversations. If you're working in a municipality or you're working for an agency that interacts with municipalities, is having clear guidance between law enforcement and EMS in a situation like the use of medications for patient sedation. It's important to think about how do we communicate that? How do we ensure that there's the smooth transition? But this can be applied to any number of things that we do. And ultimately, what came out of this, which thinking about the protection of a municipality, is in Colorado, Aurora Fire Department, the police department, and the city had to enter into a consent decree with the Attorney General's office. It is a 78-part mandate from the state and a 5-year plan of implementation to correct the issues identified by the Attorney General's office. Now, to be clear, a lot of these were actually directed towards the police department, and some were directed towards the municipality on how the interaction between the fire department and the police department occurs. But there were components in this for the fire department as well. Things such as credentialing, ensuring competency of their providers around medication administration, dosing, patient rights, all of the things that we frequently talk about. And if I were running an agency, I don't want to be on the receiving end of a 78-part 5-year plan, because the other component to this is they were required to hire a third-party evaluator to ensure that they were being compliant with this plan. They have been, but this has cost them a significant amount of money to bring in this third-party evaluator to ensure competence. And again, this is that ounce of prevention. They very easily could have spent some time, energy, and money doing a credentialing program and an ongoing training program to ensure these things and maybe not prevent the situation, but certainly provided a better opportunity for that to occur. Does anyone have any questions about any of this so far? All right, I'm not seeing any at the moment, but if they come up, please either put them in the chat or the question and answer section. So this is where we really kind of get into the meat of this. How do we right size this for an agency? I'm watching the names again in the chat here, and there's a significant spread in terms of the resources, size of agency, and the thing in your departments. So what are the things that we can do that anybody can do that are relatively easy wins? So some things that I put here are MEFR's license tracking, high risk, low frequency skills, protocol checks, and scenarios. So what does that look like? So Main EMS is actually Main EMS has already actually built a report in the MEFR system. And if you're a service administrator, or you can go in to MEFRs, you go into the tools section to report writer, and then there's a report labeled agency expiration date report. You can select this with your agency and then generate the report, or what is probably a more helpful thing is you actually can set this up as a recurring report that will automatically send to you or anybody else who you identify in the system as receiving this report. What I will tell you is the licensing board that Main EMS is seeing a pretty significant number of unlicensed practice cases that are popping up across the state. And I bring that up to say there's an easy solution here to prevent those providers and those agencies from ending up in front of the licensing board. I have always been a firm believer that the license is the responsibility of the provider, not the agency. However, the agency has a responsibility to ensure that their providers are actively licensed to provide care. This is an easy way to actually check that. So this is the trust but verify. Trust that your employees are going to do the right thing, but let's make sure that we verify it as part of this credentialing process. You can run this report. You can have it automatically send you every month, and that should help you prevent or it should help you avoid any situation where unlicensed practice goes unrecognized. And this goes back to also it checks based upon the state's licensing database, so you know that you're getting that primary source verification again. If you have more questions or you need help with this, you can certainly reach out to your regional manager. Jason Oko also said that he was one who set this up. He's happy to help people as well. But it's an easy solution to a problem that keeps rearing its head in Maine. So high risk, low frequency skills. This is not a comprehensive list that I put together. I was just trying to demonstrate some ideas. So what don't we do a lot that has significant impact on patients? Use of a BVM. As somebody working in education, I know that this is actually one of the hardest skills for new providers to actually master and do well is simply getting that mask seal with a BVM and then effectively ventilating a patient. We now have so many tools available to us in terms of measuring how much we can measure the volume that a provider is able to actually provide through a BVM. The amount of airway pressure, all of these things can be evaluated through simulation now to ensure that we're actually doing this skill effectively for patients when they need it most. And that's something that, when we're thinking about building out this list of skills and we're thinking about building out our credentialing, we want to ensure that we're not just focusing on our paramedics, where I think a lot of us automatically go to because we think about things like intubation, high risk, low frequency. It is at that license level, but where else can we bring in all of our license levels to ensure that we're doing the same things and that they're included in this process? So BVM, CPAP, epinephrine administration for anaphylaxis versus epinephrine administration for cardiac arrest management. And then when we think all the way up to paramedic, then we can start thinking about things like cricothyrotomy, needle decompression, intubation. These are all things that we don't do. Great comment just got put in. Low frequency, high risk, restraint of patients, whether that's physical restraint or chemical restraint. That is another really high risk situation and really kind of tailored is directly related to the case that we've been using to discuss here. That was restraint. That is incredibly high risk, and in that particular case, ended in a patient's death. So again, I didn't put this together to be comprehensive. I put this together as to kind of generate some thought for folks. But the thing that I really also want to stress with this is it's really important when you're thinking about credentialing and building this process is building something that you can sustain. So I would always encourage anyone, regardless of the size of the department, regardless of the resources, is think about what can you effectively manage in an ongoing basis. Build success and then build on top of that. So if you start with, let's pull out, equipment, let's start doing BVM because that's a skill at every license level. We're going to start there. We're going to figure out the logistics of how we're going to get through this, how we're going to evaluate this for all of our providers, and start there. Start with something. And then when you've got that worked out, then you build upon it. You add another skill. You keep going until you feel that you've built a comprehensive credentialing process. It would be great if we could all just snap our fingers and go from where we are today to the perfect system But one, I don't think there's ever going to be a perfect system. And two, it's unrealistic. And the resources that it actually takes to do this are significant. So figure out how to build that success and build upon it. Protocol checks. Again, thinking back to what I said originally, this can be a written exam basically. But how are you going to do this? To pull out the protocol book and look through all, I don't even know how many pages are in the app now. I'm far enough removed from the editing of that document now that I no longer know the number, but it's a lot. So how are you going to evaluate, um, is this a test? Yes. So, so the protocol checks, break it down into sections. And maybe this is something you do a section a month. Maybe you lump some sections together that naturally either fit together or from a volume standpoint are approachable. But again, thinking about where are the high risk, low frequency occurrences within the protocol, maybe those are the sections you start with. Thinking about, you know, the blue section, which I just realized I intended to make these color coded and they're absolutely not, which is great. But again, my point being here is just pick a section, build license level specific testing to ensure that people are familiar with the protocols. This doesn't have to be you've memorized every protocol, you've memorized every medication dose, treatment modality. I would encourage people to actually use the protocols because it's ensuring that they, at very least, know actually how to. Yeah, Jim, I got a 50%. It's pretty bad. I did not pass, but the point being is we want this to be familiarization with how to use the protocol and get the information if we don't know it when we need it. So this should be open book because it's going to allow providers to, again, get familiar, go through, utilize the document, which if for some reason they need that in the moment when they're treating a patient, I'd rather a provider who has opened that document a lot to review things than a provider who doesn't remember where to find what they're looking for. And that's one of the benefits of doing this is it just keeps building that familiarity. All right, scenario evaluation. This is where things can actually get a little bit more tricky because it tends to be a little bit more fluid. So what are we trying to do with this? We're trying to actually evaluate clinical decision making. We can incorporate skills evaluation into this. If we're doing these scenarios as part of a team, you could have a team lead, you can have someone who's there to actually perform skills. Um, you you really want to be thinking about utilizing program patients. And when I say program patients, what I mean is somebody whose job it is to play that patient, who is familiar with the intention of the scenario, the outcomes of the scenario, who has the background information to act as the patient to try to make this as real and a simulation as possible. In situations where we can't use program patients, use simulators. Um, Question asked, could I achieve this to start with a good case study? That is another great way to actually evaluate this in terms of clinical decision making is you can use case studies. Um, and really what you're looking for here is you're looking for, can they make the appropriate decisions? So having that program patient, that simulation, that good case study, but what we're looking for here is that whatever is being put in front of the providers is consistent and that it's measurable. We want to make sure that we have a tool that we can use to evaluate this. That tool should include expected and required treatments and outcomes of patients. This is something that education already does a lot of, and is something that I would say is always in evolution. Any scenario or case study that you're using, I would also encourage that this is a great opportunity to actually engage with your medical director to really look at these tools, look at what you're using, and um, ensure that they are engaged as a medical director, but that they're also ensuring medical relevance to what's happening. And Kevin Curry just put in here that the NREMT skill sheets are still a valuable resource for scenario evaluations. They absolutely can be. The other thing I would suggest is um, I feel pretty comfortable speaking on behalf of the community college programs. We're always happy to share tools that we use within our programs. So if there's anything that we can do to support that, please don't hesitate to reach out to us, as we do a lot of this already. But really, Chris asked the question of service medical director. Absolutely. This really should require service level medical direction to be involved. This is also, again, a great place where we start talking about PPA, EMA. I know everyone's tired of hearing about it and thinking about it, but if we're already going to be if we're already going to be working with a service medical director around policies, procedures, this is another great opportunity to engage them in the service, to develop that relationship between the medical director and providers so that there's that familiarity. So when we're doing these things, there's a comfort in the fact that this process is designed for all of us to continue learning, to continue building on this. And Kevin brings up a great point. Repetition builds the skill. Absolutely. There's a lot of skills, and I think I would say that the vast majority of providers in Maine have not done crikes. Uh, in fact, I know that to be the case. They learned it in paramedic school. How many times have they practiced that skill since they've left? For a lot of folks, my assumption is probably not a lot. But we built that repetition in their initial education. This helps build that repetition in an ongoing basis. So I really encourage all of you to kind of think about how can you integrate your medical director into this. We have the benefit in initial education that our medical directors take, at least right now, are taking our paramedic students and they're actually rotating with them in the hospital. So they're actually able to really see in real time the clinical decision making and evaluation that and assessment that our students are practicing and using, so that it really helps them shape and continue to help that provider grow and look at that look at that initial competency that we're striving for in initial education. And it's not to say that you're going to be able to replicate that necessarily at the service level, but if your medical director chooses to be involved in both the development of these scenarios, development of case studies, and the tools and how to evaluate them, and then if you're really fortunate, if they're actually engaged and involved in actually running these things and evaluating providers, the goal being that really they have the comfort that this process is there to help them succeed and to help be better, as opposed to this being, again, I keep going back to it. This is not intended to be the I got you, we have a problem, now we're going to get rid of you. It's really how do we help providers continue to succeed in a field that demands a lot of them. So there's a lot of opportunity here to really build a system that will encourage that lifelong learning and frankly require it, but as a way for all of us to help each other succeed, which are things that we know we struggle with. So with that being said, I would encourage all of you to work with your local experts, whether that is you have somebody in your agency who is really excited about cardiology and they're the person that does all the research on cardiology, is always talking about new things, talking about new treatment modalities. Maybe there's somebody who you engage and say, listen, help us build a scenario, help us build a tool, help us deliver ongoing education, because this shouldn't be a one person does all the work here. This is a great opportunity to engage, our younger providers, our older providers, every spectrum here, to come together, leverage those skills, leverage those passions to really build this out. As I said before, if you are doing this and you need some guidance on how to develop an evaluation tool, there are local training centers. Reach out to them. We're already doing this work. It's not hard for us to say, well, here's a template. Maybe you need to tweak it for your department. You need to tweak it for what you're doing. That's fine. But we have these templates. We've got these ideas built in a framework. Um, you know, many of us are happy to meet with you and kind of talk through these things, share what we've experienced, share where we have pitfalls. I will tell you right now, when you're thinking about scenario-based education, that consistency of how you approach that and how you evaluate it can be really challenging because every now and then someone will come out of left field with something you weren't anticipating. You have to figure out how to address that on the fly. But with those experiences, we can help with these tools. We can help with how to build these things out. We may even have things that we can hand you that are effectively off the shelf, ready for you to go. But again, always coming back to these things are going to always require a touchback. So every year, you can't just take this off the shelf and do the same thing. Maybe you need to tweak it because protocols have changed. Maybe you need to tweak it because medicine has changed. When I got into this field, we were still giving Lasix to patients who we suspected had CHF. We don't do that anymore. So we need to make sure that whatever we're building continuously is being updated and remains relevant, but also that we need to make sure that there's a change in what providers are seeing so that they're not just seeing the same scenario every year and they're like, okay, I can just get through this because I remember exactly what this case is. So this really is going to take ongoing resources. It's going to take ongoing effort. So sharing this across your folks, sharing this across agencies. If you already work closely with another department that's local to you, keep doing that. This is an opportunity to double down and share and leverage those experts who you have within those agencies. I'm going to pause here for a second. I really want to know what questions people have at this point or other ideas that they think are important to bring up. Eric, do you have any thoughts that you'd like to add at this point as well?
I think this might be a good point to just reinforce the usage of the medical director or your relationship with your medical director, especially when you talk about those scenarios where you have you're not 100% sure what the outcome should be based on a curveball that is thrown by a clinician in many ways. So you have that, and that seems a place where your medical director becomes very valuable to say, oh, well, actually there are studies on this, or that may be reasonable, and understanding those things. And I think it's super valuable to have your credentialing system linked with your medical direction system, because of that reason. It's that you have that expert that can help you with that.
Thank you. And so again, with this, can you use AI? Yes, there are ways to use AI, but what I would say is this is one thing that we're certainly bumping into in education right now, and it's something I've been fortunate to actually get a fair amount of training in school on right now is how to use AI properly. And what I would say is that AI is only as good as the person using it and only as good as the prompt that you provide it. So for folks who haven't used AI a lot, it really is driven off of the prompt you provide. And I think I'll share from my own experience when I first started interacting with AI tools, I was kind of writing these really broad, generic prompts of like, give me a scenario on X. And it would come back with a scenario and it'd be like built for, um, you know, a physician. I'm like, well, that's too in depth. That's not what I want. And then I'd sit there and I'd have to like tweak it and keep changing it. So what I would tell you is that you need to be really thoughtful about what the goals are that you're trying to accomplish. What resources, as Eric put in the chat, if the resources you limit it to is like you can limit it specifically to, I only want you to utilize the main EMS protocols for building this scenario. And it will, with a certain level of confidence, will stick to just using main EMS protocols. Or you might say, listen, let's put in the national EMS scope of practice model. Let's put in the national EMS education standards, the protocols, the all of the other resource tools that NASEMSO has put together around model guidelines and evidence-based protocols. And you can throw all these things at it, or you can throw multiple states at it if you're an agency that crosses multiple states. You can say, utilizing these documents, build a scenario for a paramedic for X. And then it will do that. But what is really important is now that it did it, now you need to check it. And you need to be the human in the loop is the term that's often thrown around at this point. is you have to look at what it did and you have to evaluate it and say, did it do it right? And what you'll find is that a percentage of the time it doesn't, and you need to tweak it. So using AI is a great way to generate a lot of things quickly, but it does require review and it requires your input to do it. So great question. And Eric, thanks for the added pieces there. Other questions from folks? All right, so a couple more thoughts. Oh, here's another one. Do you have recommendations for types of models for service or agency record keeping of employee credentialing, specifically in terms of ease of ensuring initial credentialing, ongoing credentialing, and when it's called on for QA or legal review? Um, I think there's a lot of ways to accomplish how you record keep. I think one of the things that we do in education that has become really important is not just documenting success, but documenting when we identify um, errors or opportunities for a student to improve. We actually document those as well. And then we document the follow-up of when that's successful because it shows, in our case, we're dealing with accreditors, and it shows that we are identifying gaps, we're fixing those gaps and reevaluating. I think similarly, that can be of benefit to an agency as you're kind of going through this process of if 100% of people are successful 100% of the time, it makes me step back and ask a question of, is that really the reality? Is this process actually really investigating at a depth and breadth that it needs to? Or, I mean, are your people really that exceptional? Uh, and you want to have the documentation to support that they are that exceptional. And if they are, that's fantastic. And then as far as tracking that documentation, I think that really kind of comes down to what resources are available to you locally, um, is important. Because some towns have policies that say everything has to live with HR, it has to live, you can't keep things, at an agency level. So I would defer to kind of what your policies are of your employer and where you can and can't keep those things. But I think having a credentialing package that lives in an employee file somewhere is important, and that gets updated in an annual basis. Um, Part of the other question here is QA, which I'm going to dig in a little bit more on how QA plays into this. And Chris Hesvita said also implementing a near miss as part of a QA/QI process, I think is so. How do we pull QA/QI into the credentialing process? And really, this is part of that ongoing. So we've hit the point where we've done all of our initial components. They've done their initial verifications. The medical director has signed off and done that. And I said that this is supposed to be an annual thing. Well, credentialing is one of those things that can kind of be an all the time thing. It's not something, again, that's a point in time. There may be specific skills that are evaluated at specific points in time, but if we're doing QA/QI, there are things that we can look at. If our providers are doing consistent documentation, are they documenting failed IVs? And if we can see that they are, and we see also the number of times that they're doing IVs successfully, we can start to see like, what is the success percentage here? That's a component of doing QI, and it's a component of kind of ongoing evaluation of our providers. If their success rate is 30%, well, what can we offer that employee to help them be more successful? Again, it's not necessarily that this should be viewed as they're doing a bad job. It's what can we do to help them succeed? What can we do to ensure that they have the best opportunity to provide good care to a patient? Because at the end of the day, this entire thing is about ensuring good patient care is happening. So utilizing QA in that way. But again, I also go back to this also is an opportunity for us to look at things at a system level. In your case, system may be your local agency. Are we seeing issues with IVs in all of our providers? Well, is this a technique problem? Is this an equipment problem? What's the issue? Do we happen to have a patient demographic that is incredibly hard to successfully start IVs on? And do we need to think about how we alter this? Like I'll call out the fact that there's pilot projects happening around using tools for IV access in the state right now. And those folks are on this call and can share their experiences with that. So again, is there something else that we need to bring to the table that can address this issue that's maybe not a specific provider issue, but a system level issue? And to me, like this is how QA ties into credentialing of if we're looking at these things on an ongoing basis, it helps us identify these issues and these challenges. As Eric said, data-driven improvement, um, to not just think about QI as I read the chart, I read the narrative. It's important to do that to ensure that that information is being conveyed in a concise and effective manner to downstream providers. So yes, reading charts is an important part of that and spot checking those things to ensure that that's happening, but also thinking about it, the data-driven improvement of at a system level, what are we seeing as our department? Where are we struggling? And how can we incorporate now ongoing education that addresses those things? Um, it's all well and good to build an education process that ensures providers can renew their license, renew their national registry every 2 years as needed. But if we're doing a really good, if we're really building a robust process, we're going to ensure that that happens, but we're also going to ensure that we're addressing those local needs based upon our QI data and based upon what we're seeing in our providers. Um, and again, thinking long term about this, if you develop this and it becomes such an inherent part of what's happening in your agency and it becomes part of your culture of success, then you start to develop this culture where providers will now bring problems to you and say, I'm struggling with this and I need some help. Because what they realize is we have a mechanism to help them, we have resources to put around them, and we have a culture that says we value people who are trying to fix shortcomings. And shortcomings might not be the right term, but they're trying to address their own needs, um, to ensure that they're providing patient care. And that is another piece of credentialing that I think sometimes gets overlooked is this is opportunity. And that's why I put the slide up earlier is this just a challenge to be addressed, or is this an opportunity for us to change culture in a positive way to really build towards this lifelong learning, data-driven improvement, opportunities for success that is centered around quality patient care and support for providers that as an added benefit also offers that provider and the agency some protection should there be a poor outcome, because you can now show we've documented all of these things that we have been doing. Here are all the things the provider's been doing. It's not the end. It's not going to necessarily stop litigation if there's a bad outcome, but it's certainly going to demonstrate we are doing the right things to try to prevent bad outcomes. And all the evidence now supports potentially that this was just a unique situation where the outcome wasn't going to change. And we can show all the things that we've done to ensure that. So here's a list of references. I'm happy. This usually goes out. Eric, correct me if I'm wrong. You share this with the folks who participated in this, and this gets posted later as well, correct? He got tired of listening to me, so he stopped paying attention, but that's okay. I think this is going to get sent out to everybody who participated. If not, feel free to reach out to me. I'm happy to share where this all came from. Eric just confirmed yes. So really at this point, it's just what questions remain for folks. If anyone else has any other ideas that they want to throw out to the group, feel free to raise your hand, throw it in the chat, throw it in the QA question and answer piece. But I just want to say I appreciate the opportunity to do this. This is something that's kind of become a passion project of mine to really start talking about credentialing in EMS. So I was thrilled when Eric asked if I'd participate in this process, and I'm happy to share any thoughts or experiences I've had with anyone that has them. So any remaining questions from people? I appreciate your participation today. Well, if there's nothing, wait, Eric, do you have anything else that you want to add for the group before folks sign off? I, again, appreciate the participation from people.
No, we really appreciate you doing this. I think it's an important piece. I think it's not a well understood role for us at service leadership. I think we all try to do our best, but I think sometimes it's nice to have this kind of clear, like, oh, here we go. These are some things we can do. And I think it's super important to mention the fact that no one could do this from, at 100% quality rating tomorrow morning without building it over several years. It takes a while to get here. And I like how you added the piece about your quality assurance program should be tied to your credentialing program because it probably makes it a little bit easier to manage in the long run, but also gives you some goal sets and everything. The only thing I thought about was as a question is, so you work with a lot of new learners, you work with a lot of new people entering our field. Do you think that having an agency that has a good credentialing program and has a ongoing training program where they consistently offer regular training and related to the work that they're actually doing, specifically to their agency, is beneficial for those many of the students you see, because does that kind of match what you're seeing with the younger student population, that they're kind of used to things are very structured, things are very much kind of built out for them, so they have a way to fit into that environment?
Yeah, it's a great question, and frankly, a good point. The quick answer is yes. As we're seeing the new generation and kind of the COVID era graduates entering, especially paramedic school, but even in our AMT and EMT classes, they are requiring more support and guidance than students have historically. And that's not actually a bad thing. What I would say that I'm also experiencing is that in a lot of those cases, their desire for support is because they really want to be excellent at what they're doing. And there is a level of anxiety about being good enough to actually take care of patients in a number of our students. And there's honestly, for some of them, there's a fair amount of self-doubt in their ability to do that when they enter the program. And we spend a lot of our time building up those students and ensuring that they understand that, yes, you have the right mindset, you have the right skill set, but now you need to keep learning and you need to keep pushing yourself and doing those things. So I think with with the generations that are coming up right now, it is going to be as beneficial to their success and honestly their retention in this profession, that we have these systems in place that continuously help them evaluate themselves to say, I can do this. I do have this skill set. Um, and I think again, that's a big piece of thinking about, retention of employees and preparing for the future with this credentialing, as you said, is it does build that support. It innately builds that support in that this generation is looking for, um, to continuously push themselves to do a better job. Um, Another piece, Chris Azevedo threw in here, verifying skills competency changed under the new NCCP model. Um, and, I think one of the challenges with that the NREMT faces is for a long time, we've been signing off on skills competency, but I don't think anyone really understood what that meant. This is something we talk a lot about within initial education. And this is something that I reflect back on as a service training officer earlier in my career, that I didn't really think about what that meant. And I think it's important that as part of credentialing, there is that skills competency where now if that comes back under the National Registry, you can really look at that and go, you know what, we really are actually evaluating this and thinking about skills competency and how we're applying that. And that sign off actually has frankly more meaning and more value to it than it did in the past. And I think that this is a really important component for the development of our profession. I think it's important for the development of some culture change that I think we're all going to have to really look hard at under PPA EMA, under the generation of students and employees that are coming behind us. I think this is all really timely. And as I said before, we're coming to the end here, but as I said before, anything I can do to help anybody kind of right size this for your agency, share tools that we have, evaluation metrics, I'm happy to do so, because I think that this is a great opportunity for us to figure out new ways to actually retain employees and help them succeed moving forward. Eric Wellman has his hand up. Yes, Eric.
Came up with one more question that I thought of while you were talking about all this. So let's say an agency does have a Sentinel event kind of issue. How does this credentialing program help them show that, or what are the benefits of a credentialing program related to when a Sentinel event actually occurs?
Yeah, it's a good question. So really what it's doing is it's creating it's kind of creating an evidence chain of the work that has been done by the agency and the provider to ensure that they are competent to do their job. So thinking about again, going back to the Elijah McClain case, when the state looked at it, the department had not evaluated at any point, do the providers know the proper way to restrain a patient, the risks of physical restraint? Did they evaluate how the providers calculated medication doses? And when they looked at that, the answer was no. And that's why part of the consent decree included those things as these now need to be done. And we're mandating it. This isn't you building a system for your own success anymore. This is we're going to mandate what you do. So I think in that circumstance, again, not an attorney, can't offer legal advice, but I think had they had documentation showing we've done these things, this was a unique situation where these events occurred and we think this is why, that consent decree may have looked different. I think it still would have existed for other reasons. But in that particular case, they would have had that documentation to say, these are the things that we are already doing. And the root cause analysis is it was actually this problem, not those. And it might have provided some more coverage for the providers in the case as well. But I can't say that with 100% certainty. There's some other resources that Mark Minkler put here, think about skills in Maine and reciprocity for out-of-state folks that are beneficial as well. And thinking about the fact that sometimes out-of-state providers, I think this is Mark's point here, is that sometimes there are differences in scope of practice from state to state and the skill set that providers can utilize. And that if you're not thinking about that at a service level, Maine EMS may license that person based upon their national registry certification. Well, right now, as an example, AEMT, there isn't rhythm interpretation and manual defibrillation. That's been a Maine specific thing. If you're not thinking about that, if you hired an AEMT from, Missouri, I don't know what the scope of practice is for an AEMT in Missouri off the top of my head. But if it doesn't include that, but you just put them out on the truck, how are you ensuring that they actually know how to do that component of their job? So that's another component to credentialing that helps you actually identify those gaps and think about what they received from education in the first place. Any other questions from folks? Sorry, Jason Cooney, I just saw you. What is a Sentinel event? So Sentinel event being an event like the Elijah McClain or anything where the expected treatment and outcome wasn't delivered would be how I would think about a Sentinel event.
Yeah, an easy one is that whatever occurred to the patient caused the patient's death.
If there are no other questions from folks, I appreciate the input of all of you who participated. And again, I'm here as a resource if you have any questions or needs moving forward. And thank you again for the opportunity to present today.
Thank you, Don. And we will send out the evaluation and some of the resources that Don sent shortly. Thank you.